This video is about shock. Shock is the poor perfusion of tissues and organs due to a sudden drop in blood pressure. There are four main types of shock: hypovolemic, cardiogenic, obstructive, and distributive, and it has been labeled on the heart diagram because you can broadly think of it as not enough blood coming in, or blood comes in but the muscle can't pump properly, or the muscle is fine but it is being restricted from pumping properly, or finally arteries that distribute the blood may be problematic. Hypovolemic shock means there's not enough blood coming in to the heart, reducing preload and hence reducing cardiac output and blood pressure. This could be due to hemorrhagic or non-hemorrhagic causes. Hemorrhage could arise from trauma or a gastrointestinal bleed. Alternatively, patients may be hypovolemic from a non-hemorrhagic cause, such as severe vomiting in the case of diabetic ketoacidosis, diarrhea, or third spacing, where fluid is not in the extracellular or intracellular space, it is in the third space, in the interstitium. Further, cardiogenic shock relates to improper contraction of the myocardium. This could be from acute myocardial infarction where the necrotic myocardium can't contract properly, or myocarditis or cardiomyopathies. Factors could also obstruct the muscle from contracting, such as constrictive pericarditis, cardiac tamponade, pulmonary embolism, or tension pneumothorax. Finally, there may be issues with distribution of the arteries, from sepsis or anaphylaxis. Due to inflammatory mediators such as TNF-alpha and interleukin-1, there is vasodilation. So distributive shock can be differentiated from the other types of shock because there will be initially warm peripheries from this vasodilation. Clinical features include respiratory distress, so tachypnea and use of accessory muscles, pallor, hypotension, tachycardia, altered mental status, decreased capillary refill, as well as being febrile or hypothermic. At the end stage, there will be organ shutdown, organ dysfunction, manifesting as oliguria, absent bowel sounds, and lactic acidosis. So there are three main stages of progression of shock. Initially, the body may be able to compensate by elevating the blood pressure. So let's look at these formulas of blood pressure and cardiac output, and we can see how the body can adapt each factor to increase blood pressure. So this can be done through peripheral vasoconstriction to increase vascular resistance, but not in the case of distributive shock. You can elevate heart rate through tachycardia, as well as increasing cardiac output through increasing contractility of the muscle, as well as sodium and water retention. Over time, however, compensation mechanisms may begin to fail, and the patient becomes at risk of myocardial infarction and stroke. Eventually, ischemic results, and there may be anoxia, hypercapnia, lactic acidosis, and ischemic necrosis. Investigations of shock will begin with ABCD assessment to evaluate hemodynamic stability. Urine MCS will help identify causative organisms, in the case of sepsis or bacteremia. FBCs may show leukocytosis and a raised CRP. When taking blood, it's important to take two different spots at two different times because this will give an indication of bacteria being in the blood and spreading in the case of sepsis. Serum lactate may be elevated due to the anaerobic environment because the body's not getting enough oxygen, and there may be hyperglycemia. ABGs would show hypoxemia, hypercapnia, and acidosis. You can also do an ECG and chest X-ray. Management has some general principles, but it's also important to address the underlying cause. So if you were to look at septic shock in particular, you must firstly ensure hemodynamic stability through hemodynamic monitoring, so checking your vitals. Supplemental oxygen should also be given to stabilize respiration. IV fluids given, e.g. Hartmann's, because this increases blood volume, which helps increase preload to increase cardiac output and blood pressure, if you remember our formulas from before. Antibiotics are given to target the specific organism shown in MCS. Generally, vancomycin for gram-positive and ceftriaxone for gram-negative agents are fairly decent bets because the likely organisms are E. coli, Staph aureus, Klebsiella pneumonia, and Streptococcus pneumonia. If these measures, however, are not successful, vasopressors should be used, As alpha-1 antagonists, they can cause vasoconstriction to increase preload and hence cardiac output and blood pressure. Noradrenaline is selective for alpha-1, whilst adrenaline is a non-selective, but it also stimulates beta-1 in the myocardium and beta-2 receptors. Thank you for watching. If you learned something or found it useful, or just want to make my mom happy, please like and subscribe, and drop a comment with any questions or any topics you want to see in the future.